In order to find a BRAF V600E mutation in lung cancer, you have to do some kind of molecular sequencing. I think now that we have, I think I calculated about 5 different molecular abnormalities in lung cancer that have an FDA-approved agent, you're at the tipping point. Ordering single gene tests is actually not health economically viable. It's actually cheaper to order a panel. And the good news is most of the next generation sequencing panels are going to include BRAF V600E, and that's where you're going to pick it up. The NCCN says that you should test everything within a broad panel, and it lists all of the things which have FDA-approved agents, and then it has an additional table of some of the things that we've already talked about that are also potentially actionable, either inside a trial or by repurposing a drug already sitting in the pharmacy. Within our own practice, we will test every advanced non-small cell lung cancer patient with a broad range. We actually do both a DNA and an RNA-based extraction for NGS testing. We do FISH testing for MET, because we believe it's the best way of calculating amplification, and we do PD-L1 immunohistochemistry. There's an interesting study saying even though these agents have been licensed, if we use BRAF as an example, since 2017, in the community, BRAF testing is only being ordered in about 30% of lung cancer patients. And that's a real tragedy. This is a targetable agent. And so, if you have the patient in front of you and you're having to think, oh, what's the box I have to check? You're doing it wrong. What you have to do is say, do the lung panel. And make sure you know that what's in that lung panel is everything that already has an FDA approval, or anything that you might want to know. If that patient was special to you and you wanted to send them for a clinical trial, you should have everything in that panel. You don't need 1 million genes. The list of things that you can actually act on is probably less than 10. There's a certain snob value in saying my panel's got 300 genes or 400 genes. That means nothing. Just make sure you know what's in the panel that's got the right stuff. In an ideal world, what you want to do is patient comes in, you're sending off molecular testing, the result comes back within a reasonable time frame, and you wait for your treatment decision until you have that information in hand. Now, sometimes that doesn't work, and there are only certain things which are in your control. Now, it may not work because the patient is crashing and burning in front of you, and so you're going to start with probably chemotherapy, and then that information can inform you later. But the thing that is in your control is saying that the tissue that you've got is adequate and that goes through the process as quickly and efficiently as possible. That means you have to speak to whoever's getting you the tissue, whether it's the interventional radiologist, the pulmonologist, the pathologist, and you all sit down in a room together and you buy them coffee and you say, look, this is what I need it for. And then suddenly everybody's on the same team. You educate the people doing the biopsy that you want as much tissue as feasible. You educate the pathologist that you don't want to do 15,000 immunohistochemistry tests that are fascinating to them but of no importance to the patient. And there are various tricks and tweaks that you can do to maximize tissue for molecular testing. In fact, we wrote that up. It was called Tips for Molecular Testing.